Everyone to this episode of your Freedom Hub's Free Market Cash Patient. I'm your host, Jeff Cantor, along with my co-host, Charles Froman. We are definitely sponsored by the Marketplace for Health, Wealth, and Freedom, and so we're excited to have you take a look at that. We are going to take a detour over there ourselves at one moment, but most importantly, you want you to understand this is the disruptors intersection. We are definitely having the key people in this world come together that are trying to help themselves and us and doctors and everybody in general. So it's an important group of people. There is an issue out there. Not everybody's noticed or figured out what it is, but it's become pretty obvious as time's gone by. And then also we're getting all kinds of mixed information. So now the information giver is going to be pretty important. And this is a prime example of what we're faced with and the doubting Thomases that we have to deal with. So we've got our work cut out for us. Now we are excited to help make things happen. And in addition to the show, we are using this very forward-looking cash app. It's kind of like the Amazon for doctors, where you find the doctor, book the appointment, pay cash, and we're done. We have a special site set up for it. It's the WOW app, so you'll want to take a look at that. And as I said, we are featuring the various websites that this is on. It's the same address for both places. So let's take a quick gander over there as we make our way over to our client today, our customer today. This is the site itself. There's a lot of great things to look at on here. We have the webinar tab under the home, and then very importantly, the continuing the conversation. So let's start there for a quick minute, because after the guest has departed, oftentimes that's just the beginning. So here's where you'll circulate back, because after this video is posted over the weekend, it'll be available on Monday. We'll also have these links in place soon thereafter that you can connect with these people and help further their cause, or you become more involved. And then in that same vein, when you go into the Freedom tab and to see this first drop down, Fighting for Freedom, here's where you're going to see all the key action items that we need to be aware of. These are things that are impinging on all of us. And so you need to deal with, sadly, all of these links, not just one or the other. And then on top of that is the various organizations that are trying to fight for freedom that you do need to be aware of. And so here's your chance to learn about them. So let's circle back, though, to the webinar tab here, and let's take a look at what that's about and find out what's going on tonight. So first off, there's a nice little bit of initial information, a breakout on the two webinars for the 2 time slots. Down here, the future guests, so you can plan your calendar. And then most importantly, the links that you go to be able to watch the videos after they're posted. And here's an example. These are the ones that are up on YouTube. And so you'll see there's an awful lot of ones that go back through time. You'll see some great ones you want to connect with. And then let's dig into today. So on that note, I'm going to have Charles jump in here and give us a rundown on today's guest.
Sure, Jeff, and welcome, Carl. It's exciting to have Carl Schuessler on finally. Jeff and I met him a couple of years ago on LinkedIn as we were networking for the Forbes featured package that we sell with sharing and HSAs, making cash patients. And we learned through Carl that HSAs and making folks shop on price is good, but not the only solution. He really educated us on the world that we don't know much about, and that's big group disruption. And we got to know other innovators in the big group space, and the Rosetta brokers is kind of a brand that some of them hold to separate them from the usual broker who just sells a insurance product for employers. Carl actually is a veteran in that group. He is looked as sort of a grandpappy among the newcomers on disrupting group benefits. He coaches a lot of them. He's known as, a pink pants disruptor or something. That, Carl, you can correct me on that phrase that we were talking about last night. He certainly is a character. And I saw him in action at the World Health Congress that Vidar Jorgensen runs a year ago when our mutual friend Jeff Ellington had me go up there. And Carl was one of the main advisors showing PowerPoints on how they're helping big companies, big local governments direct contracts, lower the out of pocket for employees, stopping the inevitable increase in insurance spend by taking out insurance. And that latter point I just mentioned has turned out to be a theme over the past few weeks. We had Nelson Griswold a couple weeks ago talk about routing out the den of vipers, which Andrew Jackson said about the big bankers, and Griswold was equating the bankers to insurers. And then last week, our outgoing CEO, Robert Steele, really honed in on how the insurers virtually guarantee ever higher premiums for employers. Yet employers still are brainwashed to think health costs cannot be controlled. And Carl has the answer with the fair cost plan. And we're looking to hear what he has to say. He purposely does not plan out his talks, which is a good thing, so he can let it roll. Isn't that right, Carl?
All right. Carl, the floor is yours.
It's Jeff and Charles, honor to be here. 7 o'clock is it Tuesday or Wednesday? I forget.
Thursday, I think. I keep forgetting
Okay.
too.
But no, it's an honor to be here. And y'all can see me. There was 2 pictures of me up there. That's the real me with clean shaven. But if we could have a little more success, we could afford some razors. And my wife's not a big fan. She's watching, I think, but of this. So anyway, it's an honor to be here. I got a lot to cover. I'm gonna fire fast, and I'll try to get it done as quick as I can. So the question is, does your annual renewal meeting look like this? And this is kind of the way most people's renewal meetings look. Maybe if we don't do anything, something magical will happen. So it's one of my favorite songs.
Ho, 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 it's magic.
And the reason I show that's a song by Palette, and probably nobody's ever heard of, in 1974, and that was kind of their one-hit wonder. But it is, what are people doing out there? Hoping something magical happens? But what if your renewal looked like this? In the words of Sheryl Crow, a change will do you good. This is absolutely possible. And a lot of the folks on the line that have worked with me know that you can do this. So what is in this for you tonight? We're going to educate you, pull the curtains back, and really show you why your insurance is designed intentionally to cost you more, and then hopefully empower you to break free of this. And I'm really tired of that status quo term, and talk about how to be an active manager of your health plan and learn more about the Fair Cost Health Plan. Also become an active manager of your health plan, and then hopefully you can save your company a lot of dollars, allowing them to put more into communities and allowing employees to save more in their retirement. Now, what's really important about that, we got to keep this money on Main Street, folks. We got to keep it out of Wall Street's hands. And right now, Wall Street's winning big time. So the key themes today, we want to talk about building employer-built healthcare versus insurer-built healthcare. That's something we talk about all the time. And also how to take active management of your spending patterns and discontinue relying on the traditional passive management approach by the BUCAs, the Blue, United, Cigna, and Humana. We call them BUCAs to keep it simple. And then we've got to relocalize care and repersonalize it and get back to more neighborhood health care where neighbors are taking care of neighbors, as my buddy Barry Murphy says. Marcus Welby MD times for you folks out there that I know I look a lot older than I really am. But if you don't know who Marcus Welby MD is, Google it. But that was back in the good old days when a doctor and a patient had a real relationship. Focus on building a community-owned healthcare versus insurer archaic-owned healthcare. And then we got to get that local care team taking care of the members. That's what has to happen. And it's the community pharmacist who's basically gone away. And we love community pharmacists, and we won't have time to tell you stories about what we've done with them, but they're great and they can actually take care of people given the chance. Not a cartel pharmacy like my buddy George Clausen likes to use cough drops from CVS, but a independent pharmacy. Sorry, George. And so forth. So again, if you can do this, you can offer 10 times the benefits for half the cost, and you can have health insurance your way and on your terms. So Mitigate Partners, real quick, it's 29 firms across the country. Everybody is independent. We own nobody. They all own themselves. And we partner together and work together. And if we have opportunities around the country that one of us digs up, then we try to marry it with a local management partner who's in one of those communities you see down there with those red pins. About 95% of us are Health Rosetta advisors, and we're always trying to offer the cutting edge of benefit solutions. What we run into a lot is these big brokerage firms. Like I'm working a case with Liz Antaya, who's watching tonight. We're doing a case tomorrow with it's a good sized company, 1,000 life company. And more than likely, they're talking to all the big alphabet houses as usual. But those alphabet houses have very myopic views of the world. In our world, Liz Antaya may find a great high performance solution, and she tells the rest of the group about it. We all look at it and then we vet it. So we can change on a dime. We're nimble. We move. And we got, obnoxiously, I don't know, it's probably 600 years of experience, but 400 is already obnoxious enough. A couple of homework assignments. If y'all don't know this book, CEO's Guide to Restoring American Dream, this is the Health Rosetta book Dave Chase wrote, who started the Health Rosetta movement. And myself and a number of other 30 people were some of the founding members and original class that came in. And the Rosetta is a blueprint for intelligently purchasing benefits and always staying on the cutting edge of solutions. And now they have ways for employers to actually come into the Health Rosetta as well. These are two other books by Dr. Marty McCary. And y'all watched the Resident TV show. It was on last night. I think the season finale is next week. Been watching, I think it's third season, but Unaccountable, Dinesh in the movie and the show is Dr. Marty McCary. And that Unaccountable book really changed my advising career. I'm a voracious reader when it comes to our business and knowledge, and it is a tremendous book. And then he wrote The Price We Pay about a year and a half ago. And it's another great book. A lot of Rosetta advisors are mentioned, a lot of case studies and all kinds of things. That work that Dr. McCary do, we really appreciate how he's getting medical bills waived when people are owing a lot of money. And then another book that most people won't have access to. If you want it, call me. We can get it to you. This was for the benefit advisors, and we got a couple of Mitigate partners who have case studies in there. And one of them is one of our hotel clients you may hear from a little bit later. Lastly, there's a new book coming out right now called Relocalizing Health, which is really what we were talking about earlier. And, again, same case studies are in there. And Marilyn Bartlett wrote the foreword. And we're going to talk about the gas Berlin in a few minutes. It's one of our bellwether client that has been doing this for almost 6 years. So the current state of insurance, y'all know this. I don't need to waste your time. We got big time system failure. Quote of the day, healthcare ain't broken, it was made this way. I say that all the time. I didn't come up with it. I don't know who I got it from, but that's why I say many others. And make no mistake about it, these folks are brilliant. I wish I was as smart as they were to design this system. So Christy Gupton has always said, all it takes is a good advisor and a little courage. And a good advisor, sure. I mean, it's important, but the courageous employer who will step out and make these changes, that's the key. And our job as a benefit advisor is to give them the courage to have their back to make that decision. So it's the courageous employer. So these videos you're going to see, the employer deserves all the credit. They were the ones that were courageous to make that step. Now, with all that being said, my buddy Hunter Schultz, who's also on this party line, I believe, he always said Mount Everest was once unclimbable. Now there's a little problem. You literally trip over oxygen bottles going up the mountain. So even though people die every year doing it, a lot of people make it. So no more excuses, and let's don't make these employers out to be martyrs by doing this and making this step. This is happening all over the country, all over the country. This is not new and unique. Y'all already showed this, you stole my thunder. That's a big problem with the system. My dad was a 40-year OBGYN in private practice in Macon, Georgia. I'm sure most of you thought I was from New York, but I'm not. I'm from Middle Georgia, and when he was practicing medicine, it wasn't that way, and it all changed in the late 80s, and it's a disaster. I mean, the average patient visits, 7 minutes? So here's your definition of neighborhood health care. I'm gonna let y'all read it as well as I can say it. And this is what it's all about. And this really is the root of everything we're trying to do. You've got to eliminate the middles, and you've got to get it back to a patient, doctor, pharmacist relationship. This is a video that was shot by Patient Rights Advocate. Just a quick background on this. I'm sure a lot of people think, Carl, you got your client do a testimonial. No, that's not the case. Patient Rights Advocate is the group that's been behind all this transparency legislations. You know, the hospital are supposed to report their pricing. Benefit advisors or brokers are supposed to show what compensation they make now. That came down in December. And the hospital, that's not working real well on the hospital side, but they're trying. Well, that was all pushed by patientrightsadvocate.org. They were the ones behind all of that legislation. Marty Jameson, Carey, Cynthia Fisher, their whole team, and what they've done is just unbelievable. And they heard about what we were doing in Florida, and they reached out to us and said, hey, can we come film some of your clients and get these stories out? We want to share it with the former HHS Secretary Alex Azar and the White House. And we said, sure. Clients agreed. And so this is the product that you get. But I want you to watch this hospital and just listen to this.
We are self-funded here at this facility and have been for 30 years. Our premiums kept going up and up and up. We're a small 49-bed hospital, and we realized that we've got to do something.
When we met DeSoto Memorial, their health plan spend was about $2.2 million. We just wrapped up the first year, and the spend was around $990,000. So they saved $1.2 million, or 54%.
It's remarkable how much you can discount the price of something if you know you're going to get paid at the time of service.
What do we eliminate? The middle. We're going direct. That's how you save. It's direct to employer contracting. We negotiated a cash knee replacement price. That hospital was 70 grand. We got it for 25.
Direct primary care, where you just pay $65 a month, and that covers all of your primary care. And sort of the bundled cash payments are two prongs of things that we can do to actually reduce the cost of health care. We also have a program that's called the Medical Advocacy Program.
They walk you through the process.
It was kind of blowing my mind when they turned around and said, well, we'll do everything for you.
Getting them to the right doctor for the right quality, lastly the right price, and at the right time. That's what this is about.
The less we have to spend on plan, the more we're able to put back into salaries, back into maybe additional benefits or increasing benefits.
It's medical expense per employee per year. When we met them, it was almost $14,000 per employee per year. It's now right around $6,000.
Biopsy comes back, positive for cancer on the left side, and a week later, I was headed into surgery. As of today, all is well. I have gone through the process, an estimated cost of $42,000. What did I pay? Absolutely nothing.
And there was a lot of cost savings. So I actually got the bill 3 days ago, $31.76. An MRI is thousands of dollars. If something were to happen to me, or God forbid, one of my family members, it's covered.
The opportunity to take this model that DeSoto has can be replicated across the country in all these rural areas. Absolutely.
Not having to sit around that board table this year and say, okay, how much of the increase is going to go to the employees out of their pockets? I was giddy. I was excited that we did not have to do that this year.
And we deserve that. I know I do.
I've seen that thing probably 400 times. Show it all the time when we're working with prospects and clients. That's pretty powerful, folks. That is a pretty unbelievable story. And again, courageous employer, a great doctor by the name of Dr. Lee Groves. And we'll talk about him a little bit later. The Florida Rural Health Association aired this and had us do a webinar for all the rural hospitals across the state of Florida back in August. And we also did it in front of the Texas legislature last year. And we also did it from a deer stand. November 19th is about 35 degrees. So y'all, we've got the condensed version. I did it in about 10 minutes. It was cold. I didn't see any deer, by the way. Not a real good day with me running my mouth. So anyhow, and then it was also shown at the DPC Nuts and Bolts. That's Dr. Gross, who brought us to the hospital, and that's how we got involved. And that was back in November 19th. It's also shown on Christy Gupton, her podcast, and we need to do part 3 and 4 after what it's been like since, but we never have. So very quickly, this is a summary. There are 157 employees on the plan. It's a 49-bed hospital, guys, and it's a 4-star hospital. And for any of you that aren't familiar with the CMS rating system, there are only 19 4-star hospitals in the big old state of Florida. So it's an excellent hospital. The challenges they face are the fourth poorest county in the state of Florida, 25,406 per capita income. Lost obstetrics in February of 18. People have to drive an hour from this 34,000, life county. And the foreign medical spend, that's the money that was going away from the hospital in the form of claims going to other hospitals, was 79%. And that was their spend, about 2.2 million. First year with FairCo, our partner, One Beacon, I'll give Christy Vago and Julie Boback and Olga some love out there. They did a video actually put out last week about this. And our stop loss partner was significant. We saved 58% in stop loss premiums on a 157 person group. Crazy. And our pharmacy was not in aggregate when we did it. We also helped them become their own PBM. That's still in process, but we weaponized the plan design, implemented DPC. If any of you out there are wondering, why would a hospital have DPC? They have doctors. That doesn't make any sense. We can talk about that later. And they hired their first full-time surgeon in county history with all the savings. So this was substantial, and the foreign medical spend went down to 62%. It's now around 40%. So we've got people actually using the hospital they work at. And, it's kind of funny in small towns, hey, I don't want Dr. Smith to see me naked, so I'm not going to go there. That changed by changing their plan design, and we rerouted all the care. So the bottom line is they saved a lot of money, 1.2 million, 54%. And the rate had a rate decrease on the stop loss premiums, first time in stop loss carrier or second time in stop loss carrier history that ever happened. So it's been a great relationship. I hope they feel the same way. And we've kind of been featured all over the place, and it's been a lot of fun. Real quick, I want to show you what 3 months on Abuka ASO. So they were with Abuka as their third-party administrator. They were self-funded, but with Abuka, Blue Cross, United, Cigna, and Humana. I can't tell you which one. And for 3 months, that was their amount of claims on that platform. They flipped to FairCo on January 1st of 19, and that was their claims over 7 months. And I hope you guys can see that without me making a big deal about it. That is crazy. Almost 2.5 times more months and barely more cost. That's the difference of what happens when you eliminate the middle. Disintermediate the system, as Dr. Keith Smith has always said. And that was their spend and the savings. So what's the bottom line? Cost equals utilization times price. It's pretty simple, folks. If you can't bring the problem with healthcare is the cost of healthcare. That's the issue with healthcare. It's the cost. But we got to work on utilization too, and we can get to that. So historically, employers and their brokers always focus on the wrong 20%, we say. You've got 20% of your expenses are in the fixed cost bucket. And that's what everyone looks at. When they look at FairCo and they're going, oh my gosh, you're in the mid 70s per employee per month. My gosh, that is crazy. It ought to be $25. Well, I don't know. Should it? Are you looking at the wrong bucket? Because 80% of the bucket's claims dollars. You better focus on that. And the key is to focus on the top 20%. And so that makes up 80%. So we can usually save 30% in the fixed cost with some strategies we also have. And then the claims bucket is where the action's at. That's where we focus. And unfortunately, the industry focuses on fixed costs, which is a huge mistake. So what you've got out there is a dereliction of fiduciary duties. I don't want to scare anybody, but this is a great cartoon that shows the DOL run around picking up pennies after, financial advisors on 401ks, but yet they're tripping over bags of money in healthcare. And so we got to stop this. And I tell you, it's just amazing to me, this cartel continues. So ignorance is not a defense available to a fiduciary. And our job, folks, in our opinions, and what we do at Mitigate Partners is it's our job to be a fiduciary steward of our clients' money, treating it like it's ours. That's how we built FairCo. We went in the marketplace for 7 years, vetting all kinds of solutions to get the best. And we get calls about 5 times a month at least, people going, hey, I want you to look at this for FairCo. And I'm like, all right, I got to listen to you, because that was the commitment we made to our client, to make sure we have the best solutions possible in their health plan. So anyway, this helps keep, we want to keep the self-insured employer with their head out of the sand, not in it. All right, so two benchmarks really matter that move the needle. And if Charles said, Carl, you're running slow, man. You got to get going, buddy, and you're dragging. And he said, what do you got? I got 2 minutes. I said, well, Charles, I can't say hello in less than 5 minutes, so I guess I better leave. No, medical expense per employee per year, drug expense per member per month. No matter what you do in a health plan, those are the only two benchmarks that matter. I don't care if you live in the South and what's my deductible compared to companies my size. Who cares? It's irrelevant. We don't even have deductibles in a lot of fair cost plans. But it is these two benchmarks that matter. So let's look at this. The national average of medical expense per employee per year is $12,125. Where's your company? And we usually come in about right here, 64% of the average is where we usually hang. So it can be done, and it is absolutely possible. And then prescription drugs is probably about 120 now, guys. I need to update my slide. And we usually hang out around the 56 range. So that's a lot of money, guys, a lot of scripts. You know, the average member has at least 12 scripts a year. So let's talk about a health plan like a house. We think a house is easy, and it's great colors. It's the University of Georgia, my Bulldogs. But, you know, red brick, people go, we don't like the color of the brick. I said, well, red's the most common brick there is. Give me a break. So let's talk about the health plan like a house for a minute. And American dreams to own a house and build a house, maybe not if you've done it. But that's the goal. So let's look at a health plan. Let's look at what we call a traditional passive plan first. And it is the easy button. It's a BUCA insurer built plan. So basically, even when the hospital was self-funded with a BUCA, they got to do some things with their plan. They worked on some deductibles and out-of-pockets, but the rest of the ingredients were baked by the BUCA. And it's passively managed, but it is easy. What we do is not necessarily easy. So we built our entire fair cost plan around the flaws in the healthcare system. And here are the flaws, and I'm not going to have time to cover them all today. The cartel, lack of pricing transparency, billing errors, traditional PPO discount game, pharmaceutical shell game, and lack of information and data. I'm going to pick on 2 of these today. If y'all want to do a part 2, or if y'all are even hadn't already left yet, we can do it later. But I mean, I ain't going and on. I'm fired up. I'm passionate. I think everybody knows that. I should apologize for that up front. So here we go. What we did, flaws were negative. So we turn them into opportunities. And so a lot of the talks, you look at our YouTube channel, Mitigate Partners, we've done the 6 opportunities talk all over the country, many different places. And that really is the key. And Fair Cost was trying to conquer and eliminate all of these issues in which we have done, we feel. So we were frustrated with the insurance companies, with the cartel, everybody, and we couldn't do anything. So we basically built a model that made the existing one obsolete. Big Buckminster Fuller fan, and y'all know about his geometric design there. So let's look at a health plan, and let's talk about Mr. Potato Head. This is something the Rosetta had used before, and we changed it a little bit, but it's an insurer-built plan. And if you know Mr. Potato Head, that's pretty good looking Mr. Potato Head. I could never make one that good when I was a kid, but it's passively managed, but it's easy. Not really delivering the results you want, but when you look at it through our eyes, it's time to hit the panic button. And so what we did is we deconstructed and unbundled the whole system and rebuilt it brick by brick, in this case, Mr. Potato Head piece by piece, into an actively managed platform. Then you come out with a human patient-centric plan. Captain America, Mr. Potato Head, if that's your choice. But you know, Charles is a difficult guy, as y'all noticed with his introduction. He's a difficult fella. So he doesn't really care about having Captain America, Mr. Potato Head. He might want Wonder Woman, Mr. Potato Head, or Homer Simpson, Mr. Potato Head. But what's important for any of these employers, guys, is for them to have their own employer-built plan. The DeSoto-built healthcare. That's what it ought to be. So why should you build? Well, we know about renting gets expensive. We all know that. And, you know, you have to go take down some debt to take a house. But insurance companies are building the plans all across America out there, guys. And then they charge you access to the network that's built in your premiums if you're fully insured. If you're self-funded, you're paying a network access fee. To what? And here's a big thing I want to spend a minute on. Insurance companies don't pay any claims. The employer and employees do. But yet, if you ask the employees, and we were working with a hospital, and we asked them who the insurance company was, they said Buca. Well, there was no one Buca, it was the hospital. That's a problem, and you need to educate your employers about that. My friend Barry Murphy always says it. We call the insurance companies the processors. They don't pay claims, they process them. Don't get into the dignity of being a payer. And as the homeowner has had choices to build a home, they got to pick their supplies, all the way down the faucets and the doorknobs. You should be able to do that with your health plan, your bricks, and then you build your house. So here's the Fair Cost Health Plan. I know everybody's dying to see it. I'm kidding. It starts with a great foundation, which is value-based direct primary care. That's where it has to start. Anytime we can get that in, it gets a little challenging when you get a company that's sited all over the country, but it's what has to happen. And that right there in itself made the biggest difference for the Southern Memorial Hospital. No question, Dr. Lee Gross, Dr. Crouch, and their office manager, Ann Horner. Unbelievable what has been accomplished down there. And then we rebuilt it brick by brick, and here are some of the bricks in the house. Lots of bricks. Now, the Bucas, the insurer-built plans, they're going to tell you they have these bricks, but they don't, because their interests are more, the more costs go up, the more money they make. That's what medical loss ratio took care of them with the Affordable Care Act. So we have a custom employer-built, actively managed health plan. Again, employer-built. And people have asked, and I don't even really ever talk about it, but why fair cost? And I think as humans, we want to be treated fairly at work. We want to be treated fairly with everything. We also want to pay a fair cost for something, not an egregious cost. And that's really why the name came up. Let's pay a fair cost. So that's the plan. And you're like, oh my gosh, that looks really complicated. Guys, it's not that complicated. To the member, to the employee, all they need to know is where the front door is. One call, that's all. They don't need to know what's behind the sheetrock. They don't need to know about the plumbing, the electrical. If that is needed, they find out through our nurse navigators and our care management teams. That's how they find out other solutions like a musculoskeletal or a chronic kidney disease solution. But we don't tell them that up front. All they need to know is where the front door is, guys. It's not that difficult. So what does your plan look like? I like the house on the left. Charles might like the house in the middle, the mansion. And my wife might like that modern house on the right. But the bottom line is your plan. You should make that choice. Don't let someone else make it. Don't let your clients be hoodwinked into that. And the other thing that drives me batty. You got many of these employers are giving free advertising space away on their ID card. It just blows me away. That's what they're doing. I mean, can y'all put my stuff and my mug on your ID card? I'd love to get free advertising. Are you kidding me? I mean, don't hide behind a Buca logo. Get your company logo on your card. All our clients have their logo. Don't give that real estate away for free. That's the problem out there in the doctor's offices and everywhere else, is they always want to know who the Buca is. And that's a problem, folks. It is your health care. It is your company's health care. All right. Just a quick plug for DPC. Our good buddy, Dr. Shane Purcell, wrote a book. If y'all hadn't seen it, you should get it. We were fortunate enough. We helped him some, and Christy Gupton helped a lot more. And we helped him learn a lot about what goes on with employers and how brokers act, etc. And it's a great book. And I tell you, it's short, and you can give your employers or your prospects that book. It's a great book. And thanks, Dr. Purcell, for all his great work. He's done some wonderful things up there in Anderson County, not far from Clemson University. All right, so here's the fair cost plan as it works for the hotel, the Gasparilla Inn. Other health plans on your right, fair cost on your left. I'm gonna go fast because I think we got a knowledgeable audience. You'll notice there's a lot of cost with fair cost. I mean, they're gonna go broke. You haven't seen something like this in 40 years. And we have an out-of-pocket that I don't think anyone's ever hit. You'd have to go to the hospital 20 times a year to hit it. I mean, how do you hit an out-of-pocket in this plan? And that's what they charge their employees for dental and vision and medical compared to most employers in the country. And here are their benchmarks. And we had a little bit of a rougher claims year last year. I need to update the numbers, but those were below what I showed earlier. And guys, this is real. This is a case study in these books. You can read it. I can email it to you. Reach out to me. I'll give it to you. It's real, and it's absolutely possible. So again, neighborhood health care. Now I want to take a minute, and I want you to watch this video by Hannah real fast. And this, I want you to hear what she says. Hannah is the person in the DeSoto video, Hanna-Barbera, that had cancer. And I want you to hear what she said. Benefits done for us, not to us. And, you know, I was scared to death to use my plan because of my deductible coinsurance. So I wouldn't use it. I wasn't taking care of myself. I don't have those issues anymore.
Well, the benefits that we have here at the hospital are more so focused on the employees. The latter part of August, I had a concern regarding my neck, and I went in to see my primary care. Listened to my concerns, and he recommended certain protocols. It was my choice of what I wanted to do. You would think with the specialist, the appointments are so far out. Within maybe 3 weeks from seeing my primary care, having my test done, getting my results, finding out that I need to have a biopsy done. Biopsy comes back positive for cancer on the left side, and a week later, I was headed into surgery. As of today, all is well. I have gone through the process, an estimated cost of $42,000. What did I pay? Absolutely nothing. So before, I was paying all that money on my premium, and I never used the plan because I was reluctant. Because if I have this copay, I'm gonna have this deductible. We don't have those issues. Every concern I've had since day one of this plan, I have addressed and have taken care of this year. And I've paid absolutely nothing out of pocket. And we deserve that. I know I do.
1.2 million, 54%, no barriers to care. How can that be when everybody's got these $5,000, $10,000 deductibles? All right. Employer journey, crawl, walk, run, fly. We like to throw everybody off the cliff with the hang glider. Everybody that knows me knows that, but I get criticized all the time. But we have to meet employers where they are, folks. That's the truth. And so that's kind of the journey. So real quick, I'm going to cover lack of price and transparency. Let's look at that brick in the house. Cost and quality guidance. I'm going to cover two things tonight, guys. I can't do all 6 opportunities. We'd be here a lot longer. So what if we bought groceries and we buy healthcare? All right. I want you to watch this video and see what I'm talking about.
There are no prices on anything here.
Oh, believe me, some of it's pretty spendy. Whoa, that's really gone up.
Stop. I don't need both, just one or the other. It depends on the price.
Oh, that's called shopping. We don't do that here. Thank you for coming in. Your bill? Your version will be mailed to you in 30 days. Good luck trying to make some sense of it.
Now, again, I know everybody's muted, but everybody that's ever seen me give this talk, I jump down the throats of the people in the audience, or when we're with an employer. They're laughing. And my answer is, why are you doing this to all your employees? Where in the world, where in America, do we actually not know the cost of what we're buying and we find out 30 days later? And we are still doing it, folks. We don't do that in fair cost. We don't do it that way at all. So even with a lot of hospitals in your network, you're basically gambling away plan dollars because of not knowing the right physician to pick. And they're throwing darts at a board coming up with these billed charges, or you got the wheel of misfortune. As I like to say, the price is right. It's what it's like going hospital to hospital. Y'all know the difference in prices. So the problem is a lack of transparency. And the networks and the BUCAs, the way they design things, there is no relationship between cost and price. They've obscured it. The copay changed healthcare forever in the late 80s, early 90s. And networks offer discounts off of these benchmarks known as the charge master at the hospitals. And the bottom line is the employee's not attached to the decision. They're totally detached. because once they hit their out of pocket, they don't care. And that's a problem. If Lonnie decides to go to $140,000 hospital for a knee replacement, that just killed the health plan. So it matters a ton. So how do we get the employees to care? I'm going to show you. So price equals quality most things in life. For the sake of argument, I think everybody would agree with that. Not in healthcare. So this is North Florida. If you take a peek, North Florida, where someone we were working with around North Florida area. Where do the employees go for hospital care? Let's take a peek. Let's look at a knee replacement. And I want you to notice the number of claims at each hospital. Watch the number of claims and then watch the correlation to the price. That's down there in Gator country. We don't want to go there. It was great to be a Gator hater. Southeast Georgia, Baptist, St. Vincent, and then Memorial. Then everybody's heard of Mayo, 544 claims, but you saw some that are almost near 1,000. So look at this spread. Big problem when your person goes to the wrong hospital. Big problem for the employer. And remember, that employee already hit their out-of-pocket max. If they have one, they don't care. So it's a real problem. So you can also go to Health City Caymans, 15,842, that great facility down there by Dr. Shetty, and with your plane flight from Orlando. That's also a good choice, and the care down there is phenomenal, and you get a pretty good little vacation at the same time. Now, the Bucas know about this. They know about all this, but they stand passively by and allow gallbladder removals for $40,000, upwards of $135,000. And they're doing it with your money. So this is Atlanta, Georgia, and I'm just going to show you real quick. This is Hospital A, Hospital B, and then Independent Endoscopy Center. The reason the names of the hospitals off, we're protecting the innocent, and or I should say guilty, but since it's being recorded, I'm not going to throw that out there. I'm not politically correct, but I do have some scruples, I think. So here's the hard part. You got an employee that lives in South Atlanta. Any of you guys that haven't been to Atlanta, we kind of got a traffic problem here. How the heck are you going to get them to drive up there to get that upper GI? How are you going to do that? You're not. And how are they going to even know what the cost is? They don't. They have no way of knowing. And by the way, Medicare pays $194 for that procedure. So what if we brought healthcare the way we buy groceries? We can actually do that. So here's the solutions. We have access to one of our partners to CMS commercial databases, cost of procedures, what Medicare pays, what the hospital bill pays, and we have a nurse navigator and advocate to help and shop for services, identify quality, cost-effective providers. And you're going to hear this 5 times real quick. In order to engage employees, you got to reward good decisions. That's the biggest key. If I walk into 10 employers, 9 out of 10 health plans make no sense on the design, and there's no steerage and there's no incentives. So this is how it works. It's overseen by a doctor, and the people call in the nurses. It's a patient advocacy team with nurses. And again, in order to engage employees, a plan design's got to reward good decisions. One more time. Now, most of these employers you're calling on, or the things we see out there, all these doctors are in the network. So how do we get an employee to pick physician B over physician I? Well, first, they don't even know, physician I is Dr. Hodak, hands of death and destruction. Great guy, it's fun to get a beer with, but you might want to go see, the physician B. How are you going to know? That's what this solution helps you do. So when we had a knee replacement that was being done down in the St. Petersburg, Pinellas County area, there are 60 doctors that do knee replacement. We said they had to do at least 50 a year, and that took the funnel to 14. Then we looked at outcomes and readmit rates, and that got us to 8. Then we looked at the cost of the implants, and 4 fell out of the funnel. What are the chances of your members at your company picking 4 out of 60? And then we looked at the deaths and mortality. Now, this information wouldn't be shared with the member. It's all in the back room, but I'd sure like to know that if that person had 4.47 people die on the table doing knee replacement. I ain't really figured out how you have 0.47. I was at half a hip or something. I mean, knee replacement. I don't know. So then we looked at the hospital facilities. And remember, wouldn't you want to go to the hospital facility that does the most of the procedures? And strange enough, they're the least expensive. So these are the kind of things that you can find out. So our solution, the data is available. You got to get it in the hands of the consumer, which we do in our fair cost plan. Nurse navigators provide the guidance. We use cash pricing whenever possible too. And we'll give you a quick example. And again, shocking, plan design must incentivize better decisions. So here's what we do with our direct cash pay plan. This is a vaginal birth down in Florida. This hospital charges $37,000 for a vaginal birth. My dad about fell out of his chair when I told him that, because he delivered babies for 40 years. $6,500 cash. And the member got 50% of the savings from what the plan was supposed to pay, up to $1,000 back. Cash. And that's the letter they take in to the provider, and you're off and running. So cash is king, folks. So you need to incentivize your plan design, or as I like to say, weaponize. But in order to gauge them, you got to reward good decisions. So here's the deal. If Charles calls the cost and quality company, because he's required to, he generally will face a penalty if he doesn't. Any pre-cert or late procedure, we want you calling the cost and quality company. And when you call them, once you make that call, you're out of penalty. And then they'll say, hey, I think you see Dr. Schuessler. He's the best doctor for you to go to for that procedure. But Charles says, no, I'm going to see Dr. Cantor. I don't really care. So his plan pays like it always pays. But if he follows the advice and sees the wonderful Dr. Schuessler, then if he has a deductible, maybe it's waived, or maybe a copay is waived. That's how you get change in a health plan. And we've had a lot of success with that. Real quick, Gasper Lynn story. I know I'm running behind.
The inn itself is, the people are kind, and the people actually care about each other, and they go out of their way to make you feel welcome as an employee, as a guest.
You know, with the benefits that the inn has brought forward to us, especially with healthcare, has been, you know, a welcome change from what was before and what I've seen in other companies as well.
The fact that everything is so hidden in healthcare across the board. I mean, the hospitals are the same way. How much does it cost? Nothing in America is sold that way other than healthcare.
Being here for 25 years at the inn, we've seen many different insurance programs come through. So when they decided to go self-insured, I didn't really know what that meant exactly and how that was going to go for us. For the last 4 years and coming to understand the insurance, absolutely. I hope we can keep it forever. It seems to work out well for both the employee and the company.
It certainly has. Yeah, I think it does align with our core values, being that we're, you know, family owned and we operate as a family.
Coming here and becoming a part of the family and receiving this type of offer meant so much to me.
We went and found and deconstructed the whole system and found the best components and brought 16 plus solutions together and seamlessly integrated them into this fair cost health plan that we've created. All of these years, the savings is probably around 1.6 million, somewhere in that range. What do we eliminate? The middle. We're going direct. That's how you save. It's direct to employer contracting.
Your benefits coordinator, in our case it's Liz, who's great, and she's always extremely helpful.
Having someone that you can call any moment of the day and say, hey, I have this issue, help me.
I am here and available to them 24 hours a day, even on the weekends, and to guide them if they have any questions about where to go, who to see, how to handle their plan.
Being that everything's transparent, there's a clear line of communication.
We can help redirect people to good care at good pricing.
We have a partnership with a local radiological facility, and because of the rates that they have agreed to, our members pay absolutely nothing.
How much money have I saved? Maybe a little over $5,000. For me and my family, that means a down payment for a home.
We're saving probably between $5,000 and $10,000 a year as a family. No, that's the difference between a few mortgage payments or college savings for my son.
Try to get the employees to understand it's a collective thing. Something we bought, you go use it or don't use it. It's our health care. If we all approach it correctly, we all have to pay less money out.
That y'all saw their plan earlier. No deductibles, no out-of-pockets. Actually, the number was 1.8 million that was saved. So I messed up. I had 3 interviews that day for all of these clients when they came down. So I'm obviously wasn't on my game. But Liz Schrock is a rock star. She's the benefits champion. It's a title and role we created. Glenn Price had a part of that as well. Glenn's leadership from the CFO position and so forth, and the courageous leadership he showed in doing this. And then Liz was critical. And guys, this is a real important position. I don't have time, and I'm sure Charles don't want me to hurry up and wrap up, but Liz is a rock star, and many of the people that know me know her story and what she does, and it's truly unbelievable. And she is the mother hen. And let me tell you one thing, you don't get between her and those members, because I guarantee you she'll open a can of whoop you know what on it. All right, so billing errors, my favorite part. So this is medical bill review. Billing errors, big problem in our country. I can't show this video, but it's a problem. Over $1 million, $1 trillion wasted every year. This video was shot in 2008 by a very, very conservative news station, as you can see. And I'm not going to play it. When I got to look at these hospitals, she shows things that are crazy, being charged for 90 IV bags when only 4, etc. So you're going to see a little bit of this. So here's what happened. October 2015, great idea. Let's switch from 17,000 codes to 140,000. Oh, that's intelligent. I mean, they got a code for being on fire water scanner, getting hit by an orca while you're out surfboarding. Makes a lot of sense. So our own U.S. government says we got problems. Equifax did a study, got problems. Services never provided, inaccurate quantity of service, bundling, unbundling. So the bottom line is, when I want to show you all this, when we go to eat, if I go to dinner with Lonnie, we get an itemized statement that we then put the credit card down for, and then we get a summary bill after it's over. The way this system works, folks, you go to a facility, any facility in healthcare, they file what's called a UBO4. The physicians use HCFAs, facilities use UBO4s. They're sending summary bills to your third-party administrators, to the insurance companies, and that's what you get. So let's look at my wife's bill. She's never seen me do this live, but August 6, 2016, my wife had a laparoscopic appendectomy. That's a UBO4 right there. Everything in yellow is wrong. Now, guys, what did I say? Healthcare and broken was made this way. It took us 3 weeks to get this from the hospital. And look at the copy we got. It's not good. So we kept on, and it was $29,984 for her laparoscopic appendectomy. We don't have time today to talk about that price. That's a whole nother day, another discussion. But that was the bill. And again, the bills are being paid by your insurance company and by your third-party administrator from that bill. How can you verify the accuracy? So we got the itemized bill. Everything in yellow is wrong. Now, the way this works is the OR works in 15-minute increments. So the OR charge was $5,654. We don't ever have a problem with that. But the problem was she got charged for a urine qualitative. That's basically an early pregnancy test. We could have gone down to the cartel CVS for $8 and gotten a early pregnancy test. $204. She got charged $90 for oxygen and $1,360 for the stapler that popped those laparoscopic holes back up. Now, guys, the OR is supposed to have those charges built in because they're necessary and integral, and that's built in the OR charge. So what they did here is they unbundled. And then we had a couple more pages of itemized bills. Notice the 5-page itemized bills. The last one's one of my favorites. We got charged for an observation room, $957. I don't even know if we were in it. I don't know if it had a view of a dumpster or downtown Atlanta. We never were there. So there were $10,694 of billing errors on that bill that were paid by the insurance company. How's that helping your health plan out there? Is that doing any favors for you? And remember I said healthcare and broken, it was made this way? This is how it used to work. Look at how simple that is. That birth of a child, 1943. All right, last example, almost done. This was a $227,000 hip replacement. There were 16 titanium screws for 97 grand. I don't believe you can buy those at Ace Hardware, folks, if you're trying to find them. Probably not. Maybe you can. They're probably the same. Who knows? But there were 16 for 97 grand. Got the bill, itemized bill. There were 4 used. Saved the client $55,000. Want to know why healthcare is expensive? It's the cost of care. It's this kind of stuff. Crazy. All right. So under most of these arrangements, if you're fully insured, you can't do this. This is just the way it goes. So when they tell you your loss ratio is 150%, how do you know the claim wasn't all messed up like this? How do you know the bill wasn't totally wrong? You don't. So anyway, we propose you break the link if you're self-funded group, and have an independent reviewer. We've got our own partner in FairCo that does a great job. We might put the cut at $5,000 or $10,000. We'll generally save 17 to 25% off facility bills. For any of you out there, real quick, if your health plan spends $10 million, about 60% on average is facilities. So take 17 to 25% off that, $6 million, and that'll give you your savings. Pretty easy to do, non-disruptive, high impact. The member never knows the program's set in place. So again, it's an employer journey. So in summary, and I appreciate your patience, I went way over. We've chosen a different path forward. I don't have time to talk about the other opportunities, but I gave you a couple in the Fair Cost Plan that are very powerful and make a big difference. And this is what we do, active management. And we aren't brokers. We're benefit advisors, but we're really not even that. We're population health managers. We're helping manage the health of the population. With the right programs in place, you can have integrated, coordinated care for your members. It can be done. And again, we are big on active data mining and getting that data to help you figure it out. We will know if Charles Froman, if he was diabetic, we'd know if he had his eye exam, his foot exam. We will know that kind of granular detail. So, build employer built healthcare versus insurer built. Do you know what your benchmarks cost are? Had never called on an employer that did know what it is. Not knowing that is like driving a car with no speedometer and no fuel gauge. Not a good idea. Employers all over the country are doing it. It is possible. It just takes a good advice and a little courage. Let us Uber your health plan before it gets Kodak. And thanks for your time. And if anybody's still there, I'm glad to take some questions.
No, we'll definitely take some questions. That was good. It definitely was running a little long there, but it was good because you covered the right stuff. So, one interesting thing, I like how you use those videos and also those cartoons, because it's a quick way for people to get it as opposed to standing there for an hour and trying to distill it down and explain it. One of the things I've always thrown out myself is it's like, well, let's say you used to deal with your doctor and now we bring this other person in to facilitate the relationship and all of this and make it cheaper, but yet they want to get paid. So explain to me, how's that going to make it cheaper than me dealing direct with a doctor? And they all sit there like, And also, like you've been describing, and I throw that out in their same face, what other business is somebody else telling you what you charge? When you do break jobs, you set the price. They don't say, oh no, Allstate only pays this. That's what you charge for that. But doctors are locked in the prices. They have no say so.
Yeah. There's a great DPC doc down there in the bottom left, the Hollywood Square dot, Eric Kroll. He's another great example of somebody doing tremendous work in the Tampa area with his Tampa Bay Direct Care Network.
Liz, I see you got your hand up.
Look what Dr. Kroll.
Sorry, that was to tell Carl to switch his video, but you did a great job, Carl. Thanks.
Oh, thank you, Liz.
Charles, I see your hand up.
Thanks, Jeff and Carl. Great presentation. Just as you were great at this at the World Healthcare Congress half a year ago, or was it even a year ago now? So this is good. This is good for employers down to, a few dozen, I'm sure. But what about the smallest employers or individuals? How can they benefit with direct payment, direct access, and zero out of pocket?
Good question, Charles. We just released what we call Fair Cost Simple Funded. So in the world of insurance, you may have heard of level funded, kind of a hybrid between fully insured and self-funded. We actually now have that, and depending on the state you're in, like state of Florida, it requires 51 or more enrolled participants, but many states have no number. It could go down to 3 or 4 or whatever. So we actually just released that program and presented for the first time. Its maiden voyage was Friday. In a group in North Florida. So it showed and demonstrated ridiculous amounts of savings. It was crazy, but yes, we have a solution actually that they can use. But if you get too small I mean, again, for us and the timing, it's hard for us to go down to that size, but some of these advisors that might want to do that and have a solution, the small employer is the biggest problem, Charles, in the whole country. And unfortunately, in our world, to do what you just saw, and again, that's like this much at fair cost. I mean, it's ask any of the advisory board members of Mitigate Partners. It's an hour and a half, 2 hour long presentation. There's a lot. And that's just going right into the heart of the matter. But we need to do something for these little employers. Unfortunately for us, I just can't dedicate the time. I mean, we're dealing with all kinds of things on a daily basis. With our fair cost plan, we just can't dedicate the time, and the people really need the help. So I would tell you that some of these advisors could have access to fair cost for smaller groups. It's absolutely out there. I mean, we can talk about it later, but other than that, it's the Sedaras of the world, ICRAs, and DPC combos, which are great. Dr. Krall's got a great practice down there. Dr. Gross has got a great practice. Dr. Purcell, and I'm sure they have a lot of those types of clients that are doing that model. We can't dedicate the time, Charles, unfortunately.
That is the challenge. Like you said, it's not worth it. It takes so long to present to one person. I can present to a group of 100. So I understand your trepidation.
And I hate it. I mean,
it's tough because they need the help the most.
I'm 100% agreement with you. Hey, listen, if they end up going to the exchange, from what I understand, I'm not an expert in it, the broker or advisor doesn't even get a commission.
No.
So then they try to charge a fee. I know somebody that does this work, and I'm not doing that. I'm not going to pay you for that. I mean, it's a mess. It's a mess. I mean, it's an absolute mess out there. And I tell you, we got a school district client with 6,500 employees. They kind of flipped to fair cost October 1. They're not calling it that, but it's got all the components of fair cost. And it's been bumpy. It's been tough. But I will tell you what it did is all of a sudden you pull that BUCA back and there's no BUCA anymore. Healthcare is a mess, folks. It's an absolute mess. And people have learned that, pulling that veil back. And we're doing some great things. I mean, and I'll just say one thing too. I think it's really, really important. Anybody that's in a fully insured plan or a self-funded plan with a BUCA, I'll give you one quick example, and I can say it as public record, so it's okay. That school district last March had an employee that had a heart transplant. We found out about it in March when the claim for $3.2 million hit, and we get an email from the person at the insurance company. And I love it because it's, we get it. Hey, here's your large claimant notification for today with an exclamation mark. And I'm like, what the heck makes you think I'm excited about getting this notice? And with the discount that, that Cigna had, it was $2.2 million. What a bargain. So their stop loss is $900,000. So they paid the claim. The taxpayer is who paid $900,000. And if it had come in our model, this is what would have happened. It would have come through the medical management, the pre-cert company, and they would have called me, the HIPAA officer at the client, our cost and quality company. You saw those examples there earlier, how that works. Our network development partner, and the third-party administrator. And we would have had that settled at $184,000. And here's the problem, guys. The key to managing claims is never have it become a claim. And that's where you have to really catch it. And the BUCAs have no incentive to do that. There is no utilization management being done. And that's another part of the active management I'm talking about. And that requires work. I mean, I'd be on the golf course and the deer stand a lot sooner, but when you're helping people get knee replacements at 5 o'clock on a Friday, you got to do what it takes. And that's what we built with this integrated coordinated care model where everyone is on the same page. And literally when there's a problem, we have a HIPAA authorized cloud board that that all our fair cost partners go to, and they're able to jump in and help that member behind the scenes, but work together. So we have every care person important to the plan, to the member, all involved in communication. We call it integrated coordinated care IC squared. Sorry to go off on a tangent.
No, that was good. I'm going to let Dr. Campbell squeeze in the last question, so both you guys will be quick would be great.
Oh gosh, thank you so much. Hey, great work. And I work with all the people you talk about. I kind of work more in the silos, like with Cynthia Fisher on price transparency. But what you're doing is much broader. You're coming in. So you have your model. I really have two questions. Are there any states or communities where you come in with your model where you just tell the client, look, I can't do it because you don't have enough DPC, you don't have enough of this or that? And the second question is, how many covered lives are you talking that you've worked, that you're currently managing?
Cover lives is probably a little over 7,000. Most of our clients, Dr. Campbell, are, and thank you for your question, are, a couple hundred. Those numbers you saw that the hotel and the hospital achieved, you saw the size of those groups and you saw the money. It's crazy. The school district saved $6 million the first year, and that was working alongside of BUCA. We hopefully we'll get to 10 or 20 million this year. And that's putting real money back in the classroom, changing the future of our country. My answer to you is, we don't have DPC in every one of them because of that spread. Like you said, if somebody's over, we got 3 employees over here and there's no DPC nearby, you just have to build the plans where you have a DPC and a non-DPC. But right now, with the DPC movement spreading and some technology that's coming online, I think it's going to be easier too. But I think it absolutely is the foundational component of the house. It is the cinder block before you lay a brick. It makes all the difference in the world. And I've learned so much from Dr. Kroll and Dr. Gross and all those, Dr. Purcell at that. And I was kind of not a proponent of it initially because I'm like, well, there's a cost to it. Well, there's already a cost in a health plan. They're already paying for it. So you just basically displace it with this, and the care and the concern and the stories we've heard, and getting people off opioids. The hospital, like most employers, had an opioid problem. We ran the numbers. We have an opioid partner that does opioid management, and we brought them in. They did the analysis. And the work that Dr. Gross and Dr. Kraus did, we looked at it again, and a year later, there was no opioid problem because they had a relationship with the doctor. They were able to have the come to Jesus meetings with the member and the spouses who were on opioids for years. That's the difference in the quality of care. But if we spread it out, Dr. Campbell, we can make this work most places. The DPC is the component that can make it hard, but the rest of it works.
What a great place! What a great place to end it tonight. A nice up-tempo remark there at the very end. So I'm glad we spent some excess time tonight, and I want to thank you so much for being here, Carl.
Sure. Well, I'm glad to take some more questions. I'm fired up now.
That's going to be meeting number 2. But thanks again.
Yeah, thank you guys. I appreciate y'all having me on the show, and hopefully it was worthwhile. And hopefully, I know some folks on there have already heard this talk 100 times, but we appreciate it. We want to thank our clients for being courageous, and thank you guys for having us on.